understand. And what I'd like to really talk about today is liver cancer, and then finish off with, starting off with a little bit about epidemiology, and then how we treat liver cancer currently. So starting off at the beginning, what am I going to talk about? I think it's very important because many patients get liver cancer that they don't know why they get liver cancer. So I'm going to talk about a little bit about liver disease and liver cancer and the causes thereof, a little bit about the symptoms and signs of liver disease and liver cancer. Then unfortunately, I will have to bore you with some statistics, and then talk about surveillance and prevention, diagnosis, and really finish off with the importance of advocacy in managing liver cancer. So just to start off in terms of the liver, I have had patients who pointed to the left side of the abdomen and said, "Is my liver here?" So just to reiterate, the liver sits on the right side of the body, and it is one of the largest organs in the body. It's about 1.2 to 1.5 kilograms in weight. And it is the largest if you don't think of your skin and adipose or fat tissue as being an organ. But of the solid organs in the body, it is the largest. And you can see that the gallbladder sits under the liver, and it's on the right side of the abdomen. So why do we get liver disease and why do we get liver cancer? I think the concept to understand is that any organ, it doesn't matter whether it's your liver or your skin or your brain or your heart, when you get a disease or damage, and the best analogy I try to use is if someone cuts their hand, takes a knife and cuts their hand, the first thing that happens is you get swelling, which in medical jargon is inflammation. And lo and behold, if you look at that same wound 6 months later, you've got a scar tissue. And so the normal response to injury of any tissue in the body, swelling or inflammation, and then scarring of the liver. Here's a normal liver, and it doesn't matter what you inflame it with. It could be hepatitis B, it could be hepatitis C, it could be alcohol-related liver disease or something rarer, or it could be fatty liver disease. And many of you may have heard of it as being NAFLD or non-alcoholic fatty liver disease. But just to bring the new name out there, it's metabolic dysfunction-associated fatty liver disease, because it's due to the epidemics of obesity and diabetes that we see. But any of these diseases eventually causes inflammation or chronic hepatitis. Then over years or decades, we get cirrhosis, in other words, the deposition of scar within the liver. And when your liver is encased in scar tissue, that's when we histologically call it, when we call it under the microscope, cirrhosis. And the perfect soil for the development of liver cancer, and this is a liver cancer out here or here, is a cancer that arises in a cirrhotic liver. So the broad principle is inflammation in the liver gives you swelling, results in scarring, which eventually gets to the stage of cirrhosis. And then cirrhosis is the ground for developing liver cancer. So cirrhosis, as I mentioned, essentially refers to a scarred and a stiff liver. And what most patients don't understand is that once the liver has cirrhosis, you've probably lost about 80 to 85% of its function. At the same time, when you come to clinic and you're told that you've got cirrhosis, you feel perfectly well. You have no symptoms and you feel completely normal. Why is that? And it's very easy to understand if you think that the liver is the central chemical factory in the body that takes in all the food that we eat. It's the first port of call, and then it's distributed all around the body. So if you have an organ that's so central, then we've been created with a huge amount of liver reserve. So your liver can be functioning normally, even though it has lost 80 to 85% of its capacity. Eventually, once you lose the remaining 15%, that's when you get into liver failure or liver cancer. And just to illustrate that in a diagram, this is how long the disease may last in a person. This might be 3 or 4 decades. This is when you feel 100%. Bottom here is when you're nearly dead, or 0 would be when you're dead. And if you think about someone who's got heart disease or lung disease like asthma or a skin disease, as their heart disease gets worse, they get chest pain, and the symptoms closely correlate with how bad your heart function is. Or in the case of asthma, you can't breathe, you'll go immediately to your doctor. And the same thing with a skin disease, you get a rash, you can see it, you immediately go, you get symptoms, it's itchy or whatever, and you go and see your doctor. But liver is very different. So your liver can be destroying itself very, very gradually over decades. But in terms of how a patient feels, they've got no symptoms. And it's usually when they destroy 85 to 90%, they're on the edge of the cliff, and then they crash with developing symptoms of liver failure. And this happens very late in the piece. And so if you go to a less well-resourced country, what you will find is that most patients in liver clinics look sick, they feel sick, and they're all wasted away because they present when they have symptoms. On the other hand, in more affluent countries, patients are picked up because they've got abnormal blood tests when they go to a GP. They're picked up early, they're tested early, and they have no symptoms, and it's entirely normal not to have symptoms. And then if you actually follow the advice we might give you, in a large part, we can preserve liver function, we can prevent the development of liver cancer, or in fact, liver failure. So what symptoms can you get when your liver is failing? And as I mentioned before, these are patients when they've already destroyed their 85% of their liver, but when they destroy their remaining 15 to 20% of their liver, the last 15 to 20%, they develop some symptoms. So you can have a very distended abdomen full of water. This is what medically we call ascites. And you can see this gentleman would look like he's got triplets because that's such a distended abdomen. And the reason you get this distended abdomen is your liver is very scarred. And normally all the blood from your intestine percolates through the liver and gets to your heart. If your liver is very scarred, then the blood cannot percolate through. And so the blood vessels leading to the liver begin to dilate, just like you would have in a dam that, if you block the dam levels rise and the veins rise. And so sometimes you can see these dilated veins on the abdomen, suggesting that these are, when you can't go through the liver, these veins develop, and this is trying to take the blood to the heart. And so ascites or fluid accumulation happens when these swollen blood vessels just start leaking fluid. And as I said, you can develop veins on the abdomen, but you can also develop these dilated veins in your esophagus. And some of you may have heard of the term varices. And varices are basically Latin for varicose veins. And these are varicose veins exactly like you would see in your leg, happening in the esophagus. These are red and juicy grapes that can rupture and they can bleed. And some patients get these little spots or liver spots that some people call them. They're called spider nevi, and they're essentially blood vessels, and they radiate with like a spider from the center. And if you press one of these, they blanch and they fill from the center to the outside, and they're called spiders or liver spots. And many people with significant liver disease might have these liver spots on their face or on the top of their chest. The last bit is having jaundice or yellow eyes. So those are the symptoms of getting liver failure. So what are the risk factors for liver cancer? So we're moving away from poor function and talking about liver cancer. So the major risk factor for liver cancer, and 80% of liver cancer occurs in the setting of cirrhosis of the liver, very diseased, scarred liver. If you look at some of the causes, it can be hepatitis B or hepatitis C or hepatitis D. Hepatitis D mainly occurs in the western parts of Asia, such as Mongolia, and also in the Middle East. But hepatitis B and C would be a very common cause. Excessive alcohol use can result in cirrhosis and give you liver cancer. Fatty liver disease, or MAFLD, as I mentioned, metabolic dysfunction-associated fatty liver disease, is probably going to become in the next decade the commonest cause for liver cancer. And as I mentioned, you damage your liver over time, and it can take decades. So age is a very important risk factor. Most people with liver cancer, the peak is in their 60s and 70s, but we do have younger people in their 30s and 40s who develop liver cancer. Liver cancer is also 3 times more common in men than in women. And that tells us that it's got something to do with the testosterone that men have and that women don't have. The testosterone is a driver for liver cancer. And that's why it's more frequent in men than in women. And there are certain environmental factors that can predispose to liver cancer. And aflatoxin, I'm just putting it there, it's very rare in the Western world. Aflatoxin is a fungus that grows, or it's a mold that grows on peanuts. It's very common in West Africa, and they store peanuts for a while, and in the Dajing province in China, which is close to Beijing. As soon as they identified aflatoxin, or the mold growing on peanuts, as a cause for liver cancer, they basically had better storage and preventing mold growing. And very quickly, aflatoxin-related liver cancer has disappeared. So it's cirrhosis, viral hepatitis, alcohol, and fatty liver. So what does liver cancer look like? So this is your liver, and this is a liver cancer, and it looks different from the normal liver. And liver cancer arises from liver cells, and the technical name for liver cells are hepatocytes. The medical terminology for liver cancer, using the term primary liver cancer or liver cancer is fine, but medically a lot of people call it HCC or hepatocellular cancer. And the reason we actually have it is to say that it's come from the liver, it's come from liver cells. Remember that there are many people who might have lung cancer or breast cancer or prostate cancer that spreads to the liver. That's what we would call primary prostate cancer, for example, with secondary liver cancer that spread from the prostate. Whereas primary liver cancer comes from hepatocytes. I'm not intending to make you squirmish, but as I mentioned, typically liver cancer, 80% of liver cancer occurs in a scarred cirrhotic liver. So this is a liver that's scarred with cirrhosis. You can see multiple nodules in the liver. These are the nodules of liver cells, and all the stuff in between these nodules is scar tissue. It's exactly the same as the scar tissue you see when you cut yourself, and you get a scar tissue a few months later. And then the green here is a liver cancer. And you can see here's another liver cancer there. The nodules in the liver are very small. Here's another one. Here's another one in a surgical specimen when you cut it open. And most of it surrounding liver, as you can see, has got cirrhosis in it. That's 80% of liver cancer. But a minority of liver cancer, maybe about 1 in 5 to 1 in 10 liver cancers that we can see, can occur in a minimally scarred liver. So it's just in the phase of inflammation, and that's when you can develop liver cancer. Here You can see this liver as opposed to the previous one. It's completely normal in terms of looking at the surface. It's very smooth and it's brown, as opposed to this liver that looks so irregular and very nodular. This is very smooth, and this is a cut surface of a normal liver. And you can see it looks really very, very smooth. And here's a liver cancer. Here's a bigger liver cancer. 80 to 90% occur in a scarred liver. About 10 to 20% can unfortunately occur in a normal liver. The best way to prevent both of these is to, if you've been diagnosed with liver disease, go and see your primary care physician or your general practitioner and get the treatment or the monitoring that's required to prevent liver cancer. So what are the symptoms of liver cancer? Now, most people with liver cancer, you detect it early. In other words, you've got some form of liver disease that your GP has detected. He puts you into a surveillance program or screening program. Then you should be able to identify a cancer if it unfortunately develops before you have any symptoms or any signs of liver cancer. In other words, you get them when they're so small that we can treat them. To get symptoms from liver cancer, it's usually quite late. And if a patient presents with symptoms from liver cancer, many times it means that it's quite a large cancer. So the symptoms you can get include weight loss, loss of appetite, a bit of discomfort on the right side of the abdomen, nausea, weakness and fatigue. You can get abdominal swelling with liver cancer. You might get jaundice. And sometimes a liver cancer can present with an itch, but that's not very common. And to explain why these patients can develop symptoms late, I've had patients presenting with an 18-centimeter liver cancer. Until a month ago, they've not had any symptoms whatsoever. So the key message here with liver cancer is if you've got liver disease, get yourself monitored so that we don't, and if you're going to develop liver cancer, we can diagnose it early before you develop any of these symptoms at a time when we can actually treat it. So this is really just trying to highlight some of the numbers. And look, I won't bore you with numbers, but just to highlight that in the, this is the World Health Organization data. In 2012, there were 14 million cancer cases and 780,000 patients with liver cancer. In 2020, we had about 18 million cancers in total, but liver cancer had jumped from 782,000 to 900,000 cancers. So probably 1 million people in the world develop liver cancer, and our numbers are increasing. And when you also look at mortality, this is in 2012, and you can see in 2012, there was 8 million deaths with liver cancer. In 2020, there were 9 million cases, 9,950,000 cases with liver cancer. And what it suggests is that the WHO currently estimates that there'll be more than 1 million patients who will die from liver cancer in 2020. So it is an epidemic that we're facing because of the diseases that cause it: hepatitis B, hepatitis C, fatty liver disease, and alcohol. The other important thing to note is this issue of what we call incidence mortality ratio. In other words, in the blue is the number of cancers that occur every year. And then in the red is the number of people that die from that cancer. So you can see in the whole world, there were about 15 million cases, new cancers diagnosed in 2012. And you can see that there was about 7 million people that died from the liver cancer. So the mortality incidence ratio is about 0.58. In 2020, you can see that had decreased. What that means is that if you look at all cancers, more people, yes, there are more people diagnosed with liver cancer, but more of them are surviving, okay? So the mortality has decreased. So if you look at breast cancer, for example, if you are diagnosed with breast cancer today, the chance that you will be alive in 5 years is 95%, because we've got good curative treatments. As opposed to that, when you look at liver cancer, the incidence ratio is, smaller numbers, 800,000, but the mortality, virtually for every one person that's diagnosed, one person will die from liver cancer. So what that is telling us, and you can see that number hasn't changed between 2012 and 2020. And what that's telling us is that liver cancer is where breast cancer, prostate cancer, and bowel cancer was 30 years ago. And we need to do something. And it's all the patients and the consumer groups and the advocates that have to push for research so that we can actually improve liver cancer outcomes. Because we can get it to where breast cancer is today or prostate cancer is. The majority of people can have meaningful life after a diagnosis. And this is also looking at outcomes. And these are some of the other cancers that people would know about: thyroid cancer, kidney cancer, melanoma. And you can see that the survival at 5 years is very good. And completely different to that is liver cancer at the bottom here. So we need to change the narrative of what's happening with liver cancer. We can't have it stuck in the doldrums of the 1970s. We need to get treatment and cures up there to benefit the patients that we have. And this is really just looking at it for Australia. I won't go into it in great detail, but you can see the cancer incidence is increasing in men and women. The mortality is increasing. And then if you look at age groups, this is a disease mainly of the 60 plus brackets, because that's how long it takes for you to get the liver damage. And then the last bit of statistics I would like to show you is looking at the number of, the rates of different cancers in terms of their growth. You can see all these common cancers have decreased in incidence in 1982 and 2019, bowel cancer, lung cancer, ovarian cancer. But you can see liver cancer has increased 378%, in other words, fourfold. And if you look at mortality here on the right-hand side, liver cancer mortality has increased, but most cancers have decreased. And even with melanoma, the risk is much lower than it was 20 years ago. So we need to do something about liver cancer. Now, that's all I'm going to actually bore you in terms of the statistics. But in terms of how do we prevent liver cancer, the most effective treatment for liver cancer is to prevent it. If you've got hepatitis C, we've got good drugs now to cure it. If you've got hepatitis B, we can suppress the virus and reduce liver cancer. With alcohol, you can reduce harmful alcohol consumption. And if you've got fatty liver from diabetes or excess weight or lack of physical activity, we can do something about it. If you've got significant liver disease already, your GP might put you into a surveillance program, in other words, a screening program. Many of the women in the audience will know that for breast cancer, we screen every 2 years. Liver cancer grows quicker than that. So the screening that we do for liver cancer, unfortunately, is every 6 months. So we would screen any patient with cirrhosis, whatever the cause, we would put them into a screening program. And then with hepatitis B, because hepatitis B can result in liver cancer without cirrhosis in some people, we also screen people at a particular age. So men over the age of 40, women over the age of 50, people from sub-Saharan Africa over the age of 20, and Indigenous Australians after the age of 50. So the take-home message from here is treat the underlying disease if you can. If you need screening, if you're cirrhotic, you need screening. If you're not cirrhotic and you've got hepatitis B, we have some age-based guidelines. So how do doctors diagnose liver cancer? We can do some blood tests, we can examine you, and then usually, because most of the patients don't have symptoms, we will actually do some sort of imaging, an ultrasound, CT scan, or an MRI scan. We usually don't do biopsies, but it may become something that we do with newer treatments, but currently we don't need to do a biopsy to diagnose it. And in the future, hopefully we can do molecular testing for cancer. So I told you that liver cancer had a poor incident mortality ratio. Why? Because we don't have an easy blood test for early diagnosis. Most of the patients don't have symptoms, so most of them are diagnosed at a late stage. And if you're diagnosed at a late stage, we can't do curative surgery or other curative treatments such as surgery or transplant or burning small lesions. The other big problem that we can improve on is a lack of good drugs. The final reason is that most liver cancers, as I mentioned, occurs on a background of cirrhosis. If your liver is already damaged, then we're a bit limited in what we may be able to do because we don't want you to go into liver failure. This is different, for example, from breast cancer or prostate cancer or bowel cancer, where the rest of your bowel or your breast or your prostate, everything else is normal and you can just remove the organ. Whereas liver, we have to be very careful. If you've already destroyed 80%, and you're going to remove the tumor and a bit of surrounding liver, we might push you into liver failure. So the key is to diagnose it early by knowing that you've got a liver disease and then trying to get curative treatments before you've got very advanced liver disease. So this is just a slide looking at the various treatments. So the first drug treatment for liver cancer was approved in 2007. It's a drug called sorafenib. And then we had a second drug over the last few years. And today in 2021, we've got sorafenib still. We've got another drug called lenvatinib. And the newest kid on the block is atezo-bev. And many people will refer to this as atezo-bev. This was approved in Australia in November last year. And then there's a few other drugs that we don't have good data for. But the three drugs that are available in Australia, sorafenib, lenvatinib, and atezo-bev. How do all cancer treatments work? And I think it's important for patients and their carers to understand cancer and to understand why and how we treat it. So if you think about a liver cancer or any cancer in any part of the body, so what happens is your cell first mutates and the genetics and the DNA in the cancer mutates, and then the cancer cell becomes fit to proliferate. In other words, this is what a liver cancer or a breast cancer is. They develop enough mutations in there to proliferate. So the cells become highly proliferative. And that's when you can see a lump. Now, the body obviously has an immune system that can look at these abnormal cancer cells, and they will try and kill those cancer cells with what we call immune clearance. Now, obviously, if your immune system is not strong enough, and the cancer also has mechanisms to evade your immune system. So here you've got 5 cancer cells. Your immune system can only kill 3 of them. So these 2 go on to multiply if your immune system is not as good. And then the last part of the triangle is for a cancer cell to multiply, it needs energy. So it needs calories to multiply itself. So when you think about three strategies to treat a cancer, is you've got multiplying cells. You can try and reduce the tumor burden by cutting it out, by surgery, by burning it, by freezing it, by doing a liver transplant, doing a mastectomy for breast cancer, or removing the prostate. Or if you want to try and use your immune system, you can give drugs that stimulate your immune system so it kills all of these cells. And today, the vast majority of treatments are based on reducing the amount of cancer and getting your immune system to fight the cancer. The last bit, which is trying to cut off the oxygen supply or the nutrient supply, the calories for the cancer, is we're doing it in a very mild degree currently by trying to block off the blood supply. There's a lot of research now going on to try and identify the specific metabolism of the cancer cell to target that, to try and prevent liver cancer. So when we manage a patient with liver cancer, obviously we want to have the patient at the center, and all of these people are equally important. Very often, the cancer care for a liver cancer patient is coordinated by a liver specialist, but a very, very important member of that team is the nurse coordinator. And I would dare say that most patients with liver cancer will understand more about their disease and their management and would be cared for by their nurse coordinator. But it's not just these two that manage liver cancer. We need good X-ray people. We might need pathologists to look at the biopsy. We might need different people to burn the cancer or freeze the cancer. We might need surgeons, transplant doctors. Sometimes we give radiation. Sometimes we give medical oncology drugs. And sometimes at some stage, our patients may need palliative care. And also, obviously, we have clinical trials. So I think the best management for liver cancer, if it's done as part of this multidisciplinary team, and it is worthwhile if you've got access, if you live in a city, to find a center that does MDT care for patients with liver cancer, because that's your best hope of getting access to all the treatments potentially available, as well as clinical trials. So if we were going to give drug therapy, general principles, we say if you're going to give drug therapy, it should only occur in the context of a multidisciplinary team. Patients should have early liver disease, because if you've got very advanced liver disease, your liver may not be able to tolerate it. When we talk about ECOG, it's basically talking about your function. Can you do everything at work? Are you bedridden on the one hand, or are you still going to work? So we want to get a person that's diagnosed early, that's got good liver function, and is basically doing most of his activities of daily living. And we want to reserve some of these treatments for cancers that we can't cure by cutting them out or burning them or freezing. We always believe that it should be done by an experienced doctor with experience in managing liver cancer. And because many of these drugs that we use, not only do we have to worry about the toxicity of the drug in general, we have to worry about adverse effects, even on the liver, because often the liver is quite diseased. And all treatment decisions should be coordinated, as I said, by that multidisciplinary team. In the last few slides, I'm just going to talk very briefly about the treatments that we have. So this is a complex slide, but this is really trying to show you the two drugs that we have, sorafenib and lenvatinib. These are the two drugs that were used before immunotherapy came. And what they do is that every cancer cell has got these receptors that are illustrated by these inverted Ys up there. And what these drugs, all of these cancer drugs do, is they bind to the drug and bind to this receptor and stops the cancer cell multiplying. So all of these, what we call anti-VEGF drugs, like lenvatinib and sorafenib, they stop the cancer cell from multiplying, and they also block off the blood vessels to the cancer. Okay, so it's getting rid of the nutrient supply. And then you've got these immunotherapy drugs that are listed here. And what they do is they stimulate the immune system, which is the other part of the pathway I mentioned, actually kill the cancer cell. So in Australia, currently, we have 3 options for unresectable liver cancer: lenvatinib, sorafenib. So both of them are what I said, anti-VEGF, which means they stop the cell multiplying and they cut off the blood supply. And then we've got atezo-bev, and the bev part of it is the same as these drugs, block off the blood supply to the tumor and prevent it multiplying. And this one is the immune stimulant to try and get your own immune system to try and find the cancer cell and to kill it. And then if you look at the data, these are a couple of the trials. So this was the first trial that was done in patients who did not get any treatment. They used to live for on average, about 8 months. And if you took sorafenib, you lived for an extra 3 months on average. This trial was done much later, and this compared sorafenib and lenvatinib. And you can see we got better at treating because we were treating patients in MDTs. And you can see these 2 drugs are exactly the same, sorafenib and lenvatinib. Between 2007 and 2017, you can see the survival had improved from about 10 months here to about 13 months. And then with this new treatment, this atezo-bev, we pushed that survival up. So this is immunotherapy, and this is the treatment that we had in 2007, sorafenib. We pushed it up to 18 months. So we've moved from no drug treatment at 8 months, moving it to 11 months, then to 13 months, and now to 18 months treatment survival. However, as I mentioned, all these drugs have side effects, and we have our nurse educators who really spend a lot of time going through all the side effects. Blood pressure is very common, diarrhea can happen, fatigue, peeing out a bit of protein in your urine, thyroid problems, and you can also get something called, you can get skin rashes, which we talk about as hand-foot syndrome, because typically you get skin rashes on your hand and on your feet. But there are a few side effects, and these treatments are not for everyone. And your best ability to get on these treatments is diagnosing the cancers early by knowing that you have liver disease and getting monitored for it. And you can see, for example, in this one, high blood pressure occurs in up to 42%. So 1 in 2 people may get blood pressure. Skin rashes up to 50%. So these are actually quite common. And then the immuno-oncology treatment, with the immunotherapy drugs, you can also get side effects because you're stimulating your immune system. You can get inflammation of any organ in the body. So you can get an overactive thyroid, you can get lung disease, you can get a flare of hepatitis because basically it's stimulating the immune system. There are some newer clinical trials. So we're not just waiting to just give the treatments that we have now. We're thinking of various treatments. We're trying to give chemotherapy with radiotherapy beads into the liver. We're trying to mix drugs with microwave ablation to burn the tumor, or we're trying to give radioactive spheres. So there's a whole lot of active research. And if you're in an MDT and if you're suitable, we might say, this is what we've got. We've got clinical trials, and you might even consider going on clinical trials. So finally, just to talk about what we can do about some of the symptoms of liver cancer. If you have liver cancer and you've got symptoms, for weight loss, the important thing is we tend to refer to a dietitian. It's important to eat a healthy diet. It's important to eat plenty of protein. And it's important to exercise, because exercise and maintaining your muscle mass allows you to resist not only the side effects of chemotherapy, but it also stimulates your immune system to be better to fight the cancer. And then we've got specific things that we talk about for loss of appetite. For example, eating more frequent meals, but smaller meats, eating what you like rather than things that you don't like. We can give you pain relief if you need it. We've got drugs for nausea and fatigue. If you've got fluid in the belly, we can remove it. And then many of these drugs, as I said, can give you an itch and skin rashes. And I don't know if you can see that, but some of the things that we do, itch is not very common as a primary symptom of liver cancer. But some of the drugs that we have can cause an itch. Remember that your skin secretes oil every day to keep it nice and waterproof. And if you remember in dry weather or winter, a lot of us get itchy. And it's a bit more a severe reaction when you get these skin rashes from these drugs. So what we tend to do, what I tell patients if they get an itch from these drugs, tell them to have short showers. Don't use soap because you're removing all the oil from your skin. Use something like QV cream or a non-soap cream. As soon as you finish your shower, and maybe twice a day, use Nivea cream or some other body lotion to keep your skin moist. If you have a shower, try and do it in a lukewarm temperature, because if you have a very hot shower, you're more likely to remove the oil from your skin. And then there are some drugs that your nurse practitioner or your doctor can prescribe to you. And there's a whole lot that I won't actually go through. But there are some medications that we can use to control your symptoms. The last thing, and these are my last two slides, I think I've hopefully tried to show you how liver cancer is such a scourge and how we haven't got to the level of treatments and that we have got with many of the other cancers. And so I think it's very, very important for patients and their carers to advocate for liver cancer, advocate for liver cancer, advocate for liver cancer. And for those of you who are interested, there's a very interesting book called The Emperor of All Maladies, which is basically cancer. And this is done by a doctor in the US. It's a big book, but it's written for the general consumer. And he talks about how breast cancer and bowel cancer and all of those things got to where they are today. And it got to where they are because patients fought and fought. We got influential people talking about it. It went to the US Congress. It went, and then they passed legislation. And now we've got all that research in breast cancer and bowel cancer and liver cancer. You also need, just like CCDR and Catherine is doing, you need to advocate for patient needs. Advocate for research on liver cancer, because every treatment we have is only because research has actually led the way. And we also need to have advocacy for liver cancer prevention and treatment and identifying patients with liver disease. And finally, just this is my last slide. At Westmead, there is a website that we've got. You can look at it on your phone. It's a very simple name, liverwellnessprogram.com. If you click that, what you'll see is this one will come up on your phone. This, I just got all these shots from my phone. You can see here it says liver cancer. If you click on liver cancer, it gives you in lay language what is liver cancer. And then if you go past that, it actually gives you some video resources on liver cancer. And we've generated these video resources in about 4 languages. It's in Vietnamese, English, Mandarin, and Cantonese. And some of the topics, each of these videos are very small, between 4 and 10 minutes what is liver cancer, screening for liver cancer, diagnosing for liver cancer, surgical treatments, non-surgical treatments. This website, some of these videos are about 5 years old and needs to be rehashed. But for those of you who want to look at it at their own leisure, please feel welcome to do so. So that's all I have to say. And I'm very happy to take questions. And thank you to everyone for listening in.